the, Shannon, does that look good?
Looks good.
Okay, nice full screen.
Yeah.
Excellent. Okay, so one of the components of the AIM bundles is providing education about obstetric hemorrhage and about your unit specific protocols, both to your own providers, but also to all of the team members who would work around pregnant women. And that's also one of the new Joint Commission requirements in the perinatal safety measures. So this presentation is provided as an example of how we would go about doing provider education, like in our own institution, and have some ideas to share at the end about how something like this can be adapted to fit different clinical environments. So this is really all about the bundles and how bundles can improve outcomes. And I would like to just mention that I don't have any conflicts of interest to disclose. There are some products that will be discussed by commercial name. I don't have any personal interest in any of those products. And the objectives will be to spend a little bit of time giving the background, laying the groundwork for why talking about obstetric hemorrhage is important, why having an organized plan for managing obstetric hemorrhage is important. And in this case, I will be talking about changes that we have implemented at UVA Health System to address obstetric hemorrhage. And that is not in any way, shape, or form to suggest that because we do it at UVA, that's the way everybody should do it, or that what works best for us will work best for every center, or that we have some ownership stake in having developed these protocols. This is just to share how we've approached it, and it might spark some ideas that will work in your setting as well. I think if there are a few key messages to take home from this presentation, the first would be that obstetric hemorrhage is still a significant cause of maternal death in the United States. Accounts for approximately 11% of maternal deaths annually in the United States. And between half and as many as 90% of them are thought to be preventable. To put some real numbers around that, between 75 and 80 women die each year in the United States because of obstetric hemorrhage, and between 40 and 70 of them are thought to be preventable deaths. That's 40 to 70 mothers who die that we can have an impact on preventing that from occurring. So let's talk about the incidence for starters. And the incidence of obstetric hemorrhage depends a little bit on how we define it. The traditional definition that I think many of us learned in medical school and nursing school in our midwifery training or nurse practitioner training is that an obstetric hemorrhage is more than 500 mLs of blood loss at the time of a vaginal delivery, or more than 1,000 at the time of a cesarean. The more contemporary accepted definition through the Revitalize program is a blood loss of more than 1,000 mLs cumulatively within the first 24 hours after delivery, regardless of the route of delivery. And that doesn't mean that we stop paying attention until it's 1,000 mLs, but this new definition places an emphasis on both a quantity of blood loss that is necessary to cause physiologic instability or likely to lead to physiologic instability, and emphasizes an extended period of risk for clinically important bleeding, that it isn't just about what happens in the delivery room, but about what happens after the patient leaves the delivery room or leaves the operating room. The incidence has been reported to be 4 to 5% of births or more, but because the new revitalized definitions are in the process of still being adopted by many organizations, and that many organizations are still adopting the concept of doing cumulative blood loss, I think we have yet to learn what the true incidence of obstetric hemorrhage is based on this current definition, but I think it's going to be higher. The etiology, I think, of obstetric hemorrhage are well known to anyone listening to this webinar, and we know that uterine atony has traditionally constituted and is still thought to constitute the greatest proportion. And the other potential causes of obstetric hemorrhage are listed here. And I think that the point to be emphasized is that obstetric hemorrhage or postpartum hemorrhage is not a diagnosis. It is a physical finding. It is a clinical event, and it is up to us to identify what the cause of the hemorrhage is and to address it, and to recognize that all of our initial treatment efforts are aimed at atony because that's the most common cause, but that we have to think about lacerations and abnormal placentation, and we have to recognize that some women may have more than one source of hemorrhage that will need to be addressed simultaneously. And so initial resuscitative efforts and initial treatment of atony while identifying the source of the hemorrhage and addressing the source of the hemorrhage through targeted treatment is what will result in resolution and favorable outcomes. As I mentioned, obstetric hemorrhage is the leading cause of maternal death worldwide and a leading cause in the United States, although it is not the leading cause of maternal death in the United States. It is, however, that third bullet point should give us all pause. It is the leading cause of death that occurs on the day that the delivery has occurred. So women who have subsequent maternal death from cardiovascular complications and venous thromboembolism and sepsis typically don't die on the day that they give birth to their baby. Women who die from hemorrhage die on the day that they give birth to their baby. It is also the leading cause of severe maternal morbidity in the United States. So this is something that should give us additional attention because women who experience an obstetric hemorrhage are more likely to require blood product transfusion, which increases the risk for alloimmunization and for blood transfusion reactions. They are more likely to undergo postpartum hysterectomy with all of the attendant morbidity, and they're more likely to experience critical illness, including ARDS, shock, DIC, and acute renal failure, and the potential sequelae of those conditions. Obstetric hemorrhage has been very much in the public news and the lay press with major series in the New York Times, in USA Today, and in NPR, and they have highlighted both the ongoing problem of maternal mortality in the United States, the relative ranking of the United States in terms of maternal mortality compared to other developed countries, and the significant disparities that exist in maternal mortality in the United States with a higher incidence occurring in Black mothers. And you can see from this data from the CDC, which is a little bit on the older side now because it reflects the period 2006 to 2010, a couple of key points come out. One is here in the box, you can see that the overall maternal mortality ratio, which is the number of maternal deaths per 100,000 live births, is more than double other developed countries in the United States, and that Black mothers have approximately a threefold higher risk of maternal mortality than white women do or than Hispanic women do. This slide breaks the maternal mortality ratio down by age group. And you can see really two key factors here. One is that age is a major contributor to maternal mortality, and women in the greater than 40-year-old age group experience the highest rates of maternal mortality, regardless of race, and that in any age group, Black women have a 2 to 4 times higher maternal mortality ratio than white women. This table breaks down different major causes of maternal death, and again shows, for example, here 11.4% of total maternal deaths are attributed to hemorrhage. And you can see the breakdown. A few ectopic pregnancies sneak in there, but you've got a lot of uterine atony, coagulopathy, placental abruption, uterine rupture or laceration as potential contributing causes. And you can see the relative contribution of other major causes. So just under 10% from pulmonary embolism, about 5% from amniotic fluid embolism, about 10% from hypertensive disorders, just under 14% from sepsis, et cetera. And the distribution hasn't really changed all that much. This graphic shows a progression over 4 different time periods from the late 80s through the 1990s, from the late 90s into the mid 2000s, and then from 2005 to 2010. And you can see that over those time periods, there was a initially fairly abrupt and then slowing decline in maternal deaths from hemorrhage, reaching kind of a plateau at this just over 10% range, where deaths from hypertension seem to come down, deaths from infection relatively level, and rising contribution to total mortality from cardiovascular conditions, cardiomyopathy, and to a lesser extent, non-cardiovascular medical conditions. Not to focus simply on mortality, obstetric hemorrhage is a major cause of severe maternal morbidity. And this paper from the group at Columbia, which was published in the Gray Journal about 2 years ago, looked back at data from the national inpatient sample for a 3-year period from 2012 to 2014, and applied the CDC definition of severe maternal morbidity, which encompasses 21 total diagnoses. A significant contributor to severe maternal morbidity is blood transfusion of 4 or more units. So they did an analysis both including and excluding transfusions. What they found was, again, the racial disparities persist, that severe maternal morbidity occurred in was more common in non-Hispanic Black women compared to any other group, affecting 26% of women who experienced hemorrhage. And then excluding transfusion, it was still more common in non-Hispanic Black women than any other group. And that Black women who had experienced obstetric hemorrhage were more likely to experience DIC and require blood transfusion, and were more likely to undergo a peripartum hysterectomy than any other group except Asia Pacific Islanders, which represented a relatively small composition of the total sample size. When we think about what we can do to try to mitigate these risks, we think about the role of the AIM Patient Safety Bundle, which is an evidence-based compilation of components which have been shown through various studies and have been endorsed by all of our major professional organizations, by ACOG, by AWHONN, by ACNM, by the Obstetric Anesthesiology Group, as having evidence to support their implementation as reducing maternal morbidity and mortality from hemorrhage. All of the AIM bundles center around these 4 components of readiness, recognition and prevention, response, and reporting and systems learning. And the link here, which the slides will be posted on the website as well after the presentation, is a live link to the AIM Patient Safety Bundle for your later reference. To break down the different components, the readiness components of the hemorrhage bundle include Hemorrhage Cart available that includes supplies, checklist, instructions for use of tamponade balloons and compression stitches in case those procedures are not performed regularly in your institution. The ready availability of hemorrhage medications, specifically uterotonic agents like Methergin and Hemabate, in a kit or in some otherwise easily retrievable unit that you're not waiting for it to come from pharmacy. The availability of antifibrinolytic treatment is something I add in here because the data supporting the use of tranexamic acid for management of obstetric hemorrhage has grown, and I think definitely has a role for us, which I'll go over in just a couple of slides. And the availability of a response team for major hemorrhages, particularly if you don't have these sort of people in-house at your center. So if you need to get interventional radiology in from home, if you need to get surgical backup in from home in the event of a major hemorrhage, having an alert or a code that can be called to easily summon these people will make the response more quick. Lastly, the hemorrhage bundle recommends, as part of the readiness components, that all centers will have protocols for emergency release of blood and massive transfusion protocols, which most institutions have adopted through their transfusion medicine service. Lastly, teams should engage in the regular performance of drills, should have regular unit education, which is a little bit about why we're having this session today, and have a culture where debriefs occur after major events in order to learn from the event and identify areas of good performance and areas of opportunity for improvement. In this presentation, I have a link which I can provide the document separately because the link won't work, to our own obstetric hemorrhage protocol and guideline, which I'm in the process of revising now. Not because, again, what I think we do is best, but it can just serve as an example for others. What we do works well for us here. And the idea is not that there's one best way for an obstetric hemorrhage protocol to work in every hospital in every state in the country, but that different components will work well in different settings, and each place has to have its own protocol. This is just an example of our hemorrhage cart. We have several of these. We have hemorrhage carts in labor and delivery. We have hemorrhage carts on our postpartum units, and you can see it's got sort of a keyboard here with a password, so it's locked because we do have Pitocin and misoprostol in here, so we have to keep the medication secured. We've got some Vaccary balloons, we got a Foley kit, we've got speculums and some suture trays and other things in here. We have the all-important scale on the top for quantitative blood loss, and our teams know where these are located and know how to get them quickly to a patient's bedside. And when we've had a patient screen positive as being at increased risk for obstetric hemorrhage, we'll actually have them preemptively in the room at the time of delivery. And this is just an example. Again, this is what we do at UVA Medical Center, and not necessarily the only way to do it. This is how we have put together emergency blood response with our transfusion medicine services. And we have two options to either get fast blood, which is a single delivery of 3 units of red cells and 3 units of fresh frozen plasma, which is delivered to the unit within 15 minutes when it's activated, and it is brought by patient transportation. So all we have to do is call the emergency operator and say, we need fast blood to such and such room, and we give the patient's name and medical record number, and then our role is done. We get back to taking care of the patient, and patient transport brings the blood as soon as it's ready, and they are prioritized to that. We can convert a fast blood to massive transfusion, or you can activate massive transfusion from the very beginning, which gets you recurrent deliveries every 15 minutes until you stop it. So they keep you ahead on products. And in this case, you get more. You get 5 units of plasma and 5 units of red cells, as well as platelets and cryoprecipitate. So every hospital has to adopt something like this, but they have to make it adapted to what their blood banking capability is at their individual center. And this is just one example of how it can be done. Let me speak about tranexamic acid just a little bit, because the results of the woman trial, which was published a couple of years ago in the Lancet, did kind of formalize the role of TXA in obstetrics. TXA is an antifibrinolytic agent that has been employed in a number of different settings, including trauma and orthopedics, for prevention and management of blood loss by reducing the breakdown of fibrin clots that have been formed. And in the woman trial, which was conducted primarily in India, it was a prospective trial of over 20,000 women who were randomly assigned to receive either 1,000 milligrams of tranexamic acid given IV over 10 minutes, or a placebo in the setting of obstetric hemorrhage. The primary outcome of this study was death from all causes or hysterectomy. It was a composite outcome, and the primary outcome was not altered by the study intervention. When they did pre-planned subgroup analyses, however, they found that death caused by hemorrhage was reduced with an odds ratio that wasn't too impressive, and a confidence interval that included but didn't cross 1. And then death by hemorrhage when the TXA was administered within 3 hours of the onset of hemorrhage was reduced with a significant odds ratio, which suggested to us that in the setting of obstetric hemorrhage, tranexamic acid does have the ability to reduce mortality, and in the process likely reduce morbidity, reduce the total amount of blood product required, et cetera. To follow on the role of TXA, a group in France conducted the TRAP trial, which was a prospective study of TXA versus placebo after the routine vaginal delivery, in addition to standard oxytocin. So these were normal deliveries. These were not deliveries that were selected for the presence of hemorrhage. And their primary outcome was they wanted to see, does using TSA preemptively reduce the incidence of obstetric hemorrhage of more than 500 mLs after a vaginal birth. And what they found was that the use of TXA preemptively at the time of a vaginal delivery did not reduce hemorrhage when compared to placebo, but they did find a significant reduction in the use of additional uterotonic agents beyond oxytocin. So that's 7% in the TXA group versus almost 10% in the placebo group. So at the present time, the role for TXA appears to be to administer it as soon as possible, but within 3 hours of the onset of an obstetric hemorrhage. It's a single dose of 1,000 milligrams given as a slow IV push over 10 minutes. And this is something that you can easily have available in your unit as an adjunct to your remaining treatments for obstetric hemorrhage. Moving on to recognition and prevention, how we can be prepared for an event in any individual patient includes first recognizing who appears to be at higher than background risk of hemorrhage. And I think we acknowledge that all women who are having a baby have a risk for hemorrhage, but we want to identify those women who are at highest risk to target our attention to, in particular, while not taking our eyes off of those women who don't appear to be at increased risk. Measurement of cumulative blood loss allows us to identify women who have experienced clinically significant bleeding before they become unstable, before we see changes in their vital signs, or before a lab value is checked and shows a reduction in their hemoglobin and hematocrit. And active management of the third stage as an evidence-based approach to reducing obstetric hemorrhage, which I'll go through some of that data. I would include in the recognition and prevention section, although it's not officially part of the AIM bundle, morbidly adherent placenta protocols. If you manage patients with placenta accreta at your institution on a plan basis, having your accreta protocol here, so you have your multidisciplinary approach, is where it makes the most sense. So let's talk about risk screening for a little bit. And what I think is important to mention and recognize, which I'm sure everybody who works as either a unit manager, a medical director, or as a quality director right now is aware, that the Joint Commission has essentially adopted all of the elements of the AIM hemorrhage bundle, as well as the hypertension bundle, as new perinatal safety standards, and are surveying to those beginning in January. And one of the components is utilization of universal hemorrhage risk screening. There are many different tools that have been developed for hemorrhage risk screening, and we'll go over some of those just a little bit in this presentation. There's not any data I'm aware of that suggests that one approach to screening is superior to another. What is superior is screening every patient universally rather than selectively. The second part of screening is, of course, how do you communicate those patients who have been identified at increased risk to the whole team, so everyone is aware when there's someone who has a higher risk that patient is on the unit, and that anyone is prepared to respond in the event of a hemorrhage. And this may occur through regular reassessments during the course of labor and during the postpartum period, and at regular unit huddles or safety rounds, which may be held on your unit. This is an example from the California Maternal Quality Care Collaborative, which many of us refer to as sort of a guiding post for developing our own protocols, because they've been doing this for a long time, and their data have shown improvements in outcome, including significant reduction in overall maternal mortality from the implementation of patient safety standards at delivery hospitals in California. And this breaks patients into low risk, medium risk, and high risk based on the presence of different risk factors. The AWHONN guideline is very similar in that it includes the similar factors that would determine a patient to be at low risk if they met all of these criteria, medium risk if they have one of the criteria in the center column, and high risk if they either have two or more of those medium risk factors, or if they have any of the factors listed in the right-hand column. And each center can adopt a strategy that works for them for screening and apply this to all of their patients. The bundles can be implemented either as part of the electronic medical record or done as a standalone screen and communicated to the team members, but the idea really is to screen every patient. The Joint Commission standard, in fact, is to screen every patient twice. Once at the time of admission to labor and delivery, and again at the time that they're transferred to the postpartum unit, to make sure that there is good communication between when transitions of care occur for a patient, that a patient has been identified as being at increased risk for hemorrhage and can be monitored appropriately. How we address this in our own center is that we activated the AWHONN screening tool, which is available in Epic. So if any of you are Epic users, you have the ability to work with your Epic build team to turn that screening tool live and have the risk screening incorporated into the admission workflow that takes place when the patient is admitted. And it leads to an icon being displayed on the L&D manager in Epic that shows each patient's risk screening result. You either get a red dot with 2 exclamation points on it if they're high risk, an orange or amber triangle if they're medium risk, and then a green dot if they're low risk. We have also incorporated adopting this into the admission history and physical. So there's documentation in the provider's note as to what the hemorrhage risk screen showed and what specific plan is in place for that patient. To show you another example of how this has been done, this is from the Oklahoma Collaborative, and they have adopted very similar criteria, but they've also adopted recommended strategies for how to manage these patients at the time of admission to labor and delivery in terms of blood preparation and any other steps that might be necessary. For example, they recommend that there should be interdisciplinary communication and cross-matching of 2 units of blood for any patient who screens is high risk for hemorrhage. These are just suggestions. These are not something that each individual center has to adopt, but it gives some guidelines for how to handle this. And again, here, how you might manage patients in the postpartum unit after they have been transferred off labor and delivery into your mother-baby unit. This again emphasizes monitoring risk factors throughout the first 24 hours after delivery and at handoff of care. And you can see in each of these sections, whether a patient's low risk, medium risk, or high risk, it is recommended that they have continued quantitative evaluation of blood loss to assess if they reach that 1,000 ml threshold for obstetric hemorrhage and potentially need closer assessment or evaluation by a provider for the cause of hemorrhage. I won't go through these additional slides in detail. These are again from California Quality Collaborative, just as another example of how you can adapt these for your own unit. The question of blood transfusion readiness is one that frequently comes up. What should we do in terms of having blood available? And there's lots of different options, but we recognize that transfusion is a relatively uncommon event in obstetric services. And we think that many of our patients who are at risk for transfusion can be identified and predicted in advance. So the range of options, of course, includes the highest level of preparation, which would be associated with the most cost, would be for every patient to have a type-in screen at the time of admission, and then to actively cross-match patients who have screened as high risk. And that is a process that I think many centers on this call probably utilize. There's an alternative strategy at the other end where you don't do any routine testing at admission. Which of course would give you the lowest level of preparation to respond to a hemorrhage, but would be associated with the least cost. And then you can adopt intermediate strategies in between, for example, getting a blood sample, but just holding it on the unit for low risk patients and sending it for cross-matching only if the patient experiences hemorrhage, and use emergency blood in the meantime. The bottom line message really from this is that, at least in hypothetical mathematical models, no strategy is cost effective. So you just have to decide for your own unit what works, what makes everybody feel most prepared to deal with a hemorrhage when it does occur. Is it having an active sample in the blood bank so we can get type specific blood for that patient as soon as possible? Or is it using emergency release blood in the uncommon event that you've got a hemorrhage that is significant enough to require transfusion? And having a strategy and educating your team about the strategy and make sure everyone knows what the approach is in your individual unit is really what's most important, rather than deciding that there's one best way to do it. Active management of the third stage is something that I think is time for every obstetric unit to adopt, because there's ample evidence from prospective studies in both high resource and low resource settings showing that the use of oxytocin initiated at the time the anterior shoulder of the baby has delivered, either at vaginal birth or cesarean birth, reduces the risk of obstetric hemorrhage, reduces the risk of postpartum anemia with hemoglobin less than 9, reduces mean maternal blood loss, use of transfusion, and use of uterotonics. And it's a simple intervention all of us can do by developing a protocol. And I would be happy to share the protocol we developed here in case anybody is looking to have one for their own institution. There is no evidence that oxytocin administration needs to be delayed while delayed cord clamping is being done, whether that's for 1 minute or for longer. Next is quantifying blood loss, and your tools for quantifying blood loss are really simple. It's a scale, and you can use your baby scale, or you can get a separate scale for QBL. And having graduated drapes, this image on the right is intended to show the difference in measurement from the calibrations on the drape, although you can't read the calibrations in the picture. And sort of the idea is that at the time of delivery of the baby, somebody needs to take a look and see how much is in the pouch, because most of what's in the pouch at that point is going to be amniotic fluid and other, maybe some urine and perhaps some other material. And then again, after placental delivery, and when the delivery is finished, to look again and subtract the difference for the quantified blood loss. And then use the scale to weigh out your blood soaked items, whether that's blue towels, surgical drapes, under buttocks drapes, lap pads at the time of a cesarean, and ideally using a calculator that's integrated into your electronic medical record, which of course all the Epic users know is there. And I'm aware that Epic is working on a postpartum calculator, which will make it easier for centers that use Epic to adopt postpartum quantified blood loss, so that it isn't overriding what's already in there from the delivery. AWHONN has a nice, pretty introductory animated video that shows the basics of QBL and why QBL is important, and then has links to their postpartum hemorrhage project that gives you other tools that can help you to implement and get traction with your team on implementing QBL if you haven't done it already. In terms of response, the bundle recommends that every center will have its own obstetric hemorrhage emergency management plan and checklists that are readily available for the team to use and refer to, so you're not relying on memory. And this is a theme that comes across actually all of the AIM bundles, and that is having a support program. A major obstetric hemorrhage, an eclamptic seizure, a pulmonary embolism, an unexpected hysterectomy, a transfer to the intensive care unit are all unexpected obstetric events, and they can be traumatic for the patient, the family, and the care team alike. And recognizing that this has an effect on everyone's emotional and psychological well-being is something that's built into these bundles, and recognizing that helping people recover from trauma is an important part of the overall management of these obstetric emergencies. So these are, again, from California, because they do such a good job with these things, and kind of takes you through the different phases of hemorrhage. So assessing risk at the time of admission, implementing routine measures at all births, which certainly includes active management of the third stage of labor, and then progressing from stage 1 to stage 2 to stage 3 hemorrhage, and having different responses built into that. Now, you can register yourself for the California Quality Collaborative webpage and get access to all of their information on there. I don't expect you to be able to really read this slide or digest it in just a short period of time. But this gives examples of how you might respond to a stage 1 or a stage 2 or stage 3 hemorrhage with different uterotonic medications, different activations of emergency response, different activations of your emergency hemorrhage or emergency transfusion protocol in your own center. And I encourage you to use their resources, which are freely available, and they welcome people to borrow them and adapt them for their own use. But to learn from the people who have already done the hard work of developing these protocols. A new tool which may become available to us soon is this intrauterine vacuum device. And I share this because the device has been cleared by the FDA. Our hospital happened to be one of the participating centers in the PEARL study, which was a study of a little over 100 women who were experiencing postpartum hemorrhage. And you can see this is a pretty high risk group, because over a third of the women ended up having transfusion as a consequence of their hemorrhage. And it's this neat little vacuum device that you can place into the uterus, and it's got a balloon that kind of helps hold it in place and seal off the cervix. And you attach it to wall suction at 80 millimeters, and it sort of collapses the uterus down in around it. And the typical time from initiation and insertion of the device to resolution of the hemorrhage was 3 minutes. And it's a pretty neat tool The average indwelling time was about 3 hours, and then you can take the suction off and see if the patient kind of basically has had a chance for the uterotonics and the resuscitation to catch up. The link there to Alydia Health can give you some more information about it. I don't have any direct interest in this product other than the fact that it's going to be an interesting additional tool in our toolkit and something that may ultimately supplant the use of tamponade balloons. Another sort of question that often comes up is, well, how should we really manage hemorrhage when we get to the point of needing to do transfusion? Should we give our transfusions just based on volume of blood loss and choose how much red cell and how much plasma in particular to administer? Or do we have opportunities to utilize laboratory techniques to help us refine the amount of blood product we're giving and hopefully reduce the likelihood of transfusion reactions? Our standby for a long time has been volume-based transfusion. When you reach certain thresholds of hemorrhage, start giving blood. Don't wait for laboratory results. Don't wait to check the coags or the hemoglobin and the hematocrit. Don't get behind, basically, because once you get behind in coagulopathic, you end up with a patient who's more difficult to resuscitate and ultimately may use more products. And so the idea of volume-based transfusion is really based on the physiologic principle that uterine blood flow in a term pregnancy is 15 to 20% of the mother's cardiac output, which is over a liter a minute. That in losing whole blood, clotting factors as well as red cells are lost and coagulopathy can occur. And at a specified point in the hemorrhage, the administration of both packed red blood cells and fresh frozen plasma in a fixed ratio, which is often 1-to-1, is recommended. Now, many have begun to advocate for the idea of lab-based transfusion, which is based on a combination of both physiologic principles and laboratory assessment. And let's just acknowledge that the volume-based transfusion protocols have been adapted from other settings of massive blood loss, including trauma, and other settings where blood loss occurs rapidly and sometimes not in a controlled fashion, which is very similar to an obstetric hemorrhage. One of the things that's very different physiologically in a pregnant woman, however, is the increased concentration of fibrinogen, which provides one of the physiologic guards against massive blood loss. We know that the typical term pregnant patient is a fibrinogen between 4 and 6 grams per liter. And we know that you got to get below 2 grams per liter before you're likely to progress to a severe hemorrhage. And so if you have, for example, the ROTEM, rotational thromboelastometry assay available in your hospital, this looks at clot formation and dissolution and analyzes different components of the clotting cascade and helps guide therapy. It's not available everywhere, and the time to get a result is at least 5 minutes before you start having any results. But there are some components of it that can be very helpful. So this component, the FibTem-A5, represents the fibrinogen component, amplitude of that at 5 minutes into the clot. And it measures the effective fibrinogen. If it's less than 12 millimeters, and this is all just displaying on a screen that you can interpret, and the results just keep kicking out as the clot forms, corresponds to a fibrinogen of less than 2.2. So if you're below 12 at 5 minutes, you've got a low fibrinogen, and it's very reasonable to go ahead and start giving some clotting factors at that point, along with red blood cells if the patient has ongoing bleeding. At Liverpool Women's Hospital, they analyzed the impact of implementing ROTEM, which they started quite a while ago because ROTEM was available in Europe before it was in the United States. And they adapted from what they called a shock pack response, which sounds very British to me, where they sort of automatically gave 4 units of FFP, 4 red cells, and a unit of platelets for a patient having a major hemorrhage, to giving component therapy only guided by ROTEM. And what they did is if they had a low FibTem, they used a threshold of 7, which is low, or between 7 and 12 if there was ongoing bleeding, to use that as a threshold to give fibrinogen concentrate, Riostat, which is available in the US, and looked at other components to help make a decision about whether or not to give platelets, and then look back at the 4-year experience of this implementation. And what they found was that over 32,000 births, almost 900 of those women, or nearly 3% of them, had experienced a blood loss of more than 1,500 mLs. And of them, about 200, or 23%, had a FibTem-A5 of less than 12 millimeters. And what they found that in the women in the ROTEM algorithm group, when compared to a prior group where they just gave products based on volume of blood loss without any laboratory input, they found that there was a lower incidence of transfusion-associated circulatory overload, also known as TACO, but also fewer ICU admissions, fewer hysterectomies, and less frequent utilization of more than 5 units of blood. They also seem to use less FFP and cryoprecipitate, more total blood products, but more fibrinogen concentrate. And so if you have the availability of ROTEM in your center, you may want to have a discussion with anesthesiology and with transfusion medicine about how it can be incorporated into your obstetric hemorrhage management. Finally, when you're going to implement change, you need to have the ability to look at the effect of the change and how you communicate the effects of the change to the team who are doing the work every day. I think people like to make changes that they know are improving patient outcomes, and they don't necessarily want to feel like they're doing work that isn't actually improving things. Huddles are really important. Huddles are an opportunity to talk about high-risk patients and put a plan together that's proactive. Huddles are an opportunity after events to debrief and identify successes and opportunities. And having a culture of huddles allows everyone to talk and everyone to have an input and bring up suggestions. And you are guaranteed to get helpful suggestions from the patient care tech on the unit, the OR tech, the first-year OBGYN resident who observed something that nobody has picked up on before. So it's really an opportunity to stand aside and listen to what people have to say and learn from it. A multidisciplinary review of serious hemorrhages is sort of stipulated by the Joint Commission. Transfusion of more than 4 units of blood or transfer rather to the ICU has been designated as severe maternal morbidity, and a root cause analysis or a focused review needs to be performed. And this is, again, an opportunity to figure out where are the holes in the system and how can we close those holes to reduce the impact of hemorrhage. Lastly, monitoring outcomes and process measures in your perinatal committee and communicating those results is really important for people to feel like the changes that they are implementing and that have been hard for them to implement and required them to change sometimes long established work patterns are having an impact. So I was very happy to be able to share with our group that when we looked at our baseline in 2017, we looked at what were we doing for transfusion. We were transfusing a little over 3.5% of our obstetrics patients. And at the beginning of 2018, we implemented active management of the 3rd stage for all deliveries, and we started doing QBL in the operating room. So we had a more accurate assessment of blood loss at the time of our cesarean deliveries. And a year later, we had dropped our transfusion rate by 2 patients, despite about 200 more deliveries, which resulted in about 0.4% reduction in transfusions. At the beginning of the next year, we had been working on a protocol to address iron deficiency anemia in the prenatal period with enhanced use of IV iron for anemic patients who weren't responding to oral iron, and extended QBL to all deliveries. And over the course of the next year, I was happy again to be able to report to them, and I apologize, that should say calendar year 2019 on that bottom line, to 2.8%. So really over a 2-year period with some clearly definable points in time when we made a change in practice, we were able to reduce the number of pregnant women requiring transfusion at delivery from 3.5% to about 2.8%, which everyone seemed to view as a favorable outcome. To break it down a little further, there was a very steady rate of just about 0.4% of women who required 4 or more units of blood. And these were almost always the patients who had an unrecognized accreta or who had like a significant extension of the uterine artery or the hysterotomy into the uterine artery, or maybe a uterine rupture or something else like that. So that rate didn't really change very much. But the number of women, total women getting a transfusion who only got 1 or 2 units went up, which of course translated means the number of women needing 3 units went down. So we're giving less blood to achieve the same goals. And to kind of set a target, what we saw here is that women who got 1 or 2 units of blood About half of them at the time of admission had a hemoglobin less than 11, which gave us the opportunity to think, well, what else can we do to improve the prenatal identification and treatment of anemia so that even if they do experience a hemorrhage at the time of admission, they're less likely to require a transfusion because their pre-delivery anemia had been corrected. There's a couple of slides here of references, and one of them I want to bring your attention to, and that's this last one with the YouTube link. And if you've never heard Mr. Charles Johnson's presentation about his wife, Kira, and how she died from obstetric hemorrhage after a scheduled cesarean on the day that she delivered their second child, it is well worth your time. I've heard him speak in person twice. He gives a very powerful presentation. It certainly highlights many factors about obstetric hemorrhage that could be educational to all of us. And I think it's very tempting when you listen to him talk and hear him describe the course of events on the day that Mrs. Johnson died, to think, how could they be doing that? How did they not know she was bleeding? Why were they ordering a CT instead of taking her back to the operating room? And I think those are the wrong questions. I think the question is, could this happen in my hospital? And what do I need to do to prevent that from happening? So that was really intended to be an example of like what we use in our center for provider education and update about obstetric hemorrhage and how to deal with it and changes that we've made and the impact of changes and to get feedback from people. But what we do may not work the same way at other hospitals. And I try to think about different things that might play into that. And some of it had to do with responses that we've seen in prior rounds of the AIM survey, where there's some real wide variation in percentage of the nursing staff who have received education about obstetric hemorrhage versus percent of the professional physician and midwife staff who have received education about obstetric hemorrhage. And I think as you think about planning this out and recognizing that meeting provider education, separate from being one of the goals of implementation of the AIM bundle, is also one of the expectations of the Joint Commission measure. The things that you might think about as you plan out how you're going to do your in-house education is how many providers do you have to be educated, and how can you reach that entire audience? How many different types of providers do you have? Do you have trainees in your hospital? Is it part of their educational program, whether it's midwifery students or residents? Do you have mostly or all employed or contract physicians like hospitalists, or do you have many providers who are independent practice and are not employed by your health system? Do you or do you not have midwives, and how do they play into it? You know, in theory, you would think midwives have low risk patients, but any patient can have an obstetric hemorrhage. They need to be included in the educational programs. Utilizing tools that have been made available and will continue to be made available through AIM and through VNPC may be useful to you. And you got to think about, you know, will a carrot approach help? So can I offer CME credit to the providers? Can we serve breakfast and coffee when we have our meeting? Of course, you're doing it all by Zoom right now, so I guess not. Or do you just simply, you know, sort of say, hey, the Joint Commission has said we got to do this, we got to do it. You don't have a choice to not participate in hemorrhage education because we need to be able to demonstrate that we're meeting this measure. And I think there's many different formats you can use. A live presentation is always great because it can be multidisciplinary, it can be interactive, and you can get 3 or 4 speakers. So rather than, you know, being gracious and listening to me talk for the last 50 minutes, you can have 3 or 4 different people who talk about different components of your unit specific hemorrhage protocols and the background about obstetric hemorrhage and the impact of obstetric hemorrhage. It can be paired with simulations and drills in the unit. So in addition to having a little presentation about here's our screening process and here's how we're going to identify who's at highest risk for hemorrhage. Now let's do a hemorrhage drill and let's debrief afterwards and talk about how we can run our hemorrhage response more effectively. The hard part about live presentations is it's very hard to reach all providers unless you're willing to offer it multiple times over the course of a couple of weeks and on different shifts and everything else. A recorded presentation with required viewing would at least make it easier to reach all of the providers, but would not be very interactive and is really passive learning. Computer-based modules, of course, would also reach all practitioners, and you would also get documentation of participation because there'd be a little quiz question at the end or something. And they are really very minimally interactive, of course, and most people, like when they get assigned another computer-based module to complete, they either yawn or curse or both. So that concludes my formal presentation. I can go ahead at this point and open up the chat box and kind of look at what questions folks have put in, and I'll be happy to try to respond to them, and we can open it up for live questions as well. And I'm just kind of scanning through here. Thank you everybody for kind of identifying yourselves and where you're from. We're glad to have so much participation from all over Virginia. And so Donna, maybe since you have put the only question in the chat, maybe you would like to just unmute yourself and ask the question and maybe prompt some discussion about it.
Yes,
and thank you for your question.
Yeah. So we've been working to develop materials that we would provide in the event of an adverse event for not just OB hemorrhage. And as we've worked through several bundles, we've realized that it needs to be a little broader. And I'm hoping to not reinvent the wheel. I'm hoping that somebody else has examples out there. But we have a solid program for support for staff and providers. And we're really looking at something that can support at the time of event, that the staff or provider would go in and share with a family member or the patient per se. And that I'm really looking for something that maybe has already been developed. Hope that makes sense.
Does anybody have any a program at their place? I will say that's one of the areas we're really still working on as well.
You know, while we're waiting on someone to chat in, I will also add this. When you were talking about how to do the risk assessments, we have Epic, and we actually built our risk assessments into our order sets. So they're hard stops for the providers at the time that they launch the admission order set and at the time that they launch the postpartum order set after delivery. So they're hard stops, and the hard stop has the orders for labs or whatever based on the risk assessment that they do on admission or post-delivery. And they're very helpful, actually.
That's great. Thank you. Yeah, the way we activated it is it's in the nursing admission workflow, and so the nurses are completing it, and we have not had any challenges with that either. So I think it's just what works for each center. I did find because I was trying to look and figure out what we could do at our place. I can find where this is and try to have Shannon post it or email it around. But online, I found a document called COPE, Communication for Obstetric and Perinatal Events Resource Guide from Einstein Montefiore in New York. And it's just about a 8 or 9 page resource guide that kind of helps if you've had an event, gives the unit leaders and others some suggestions for how to frame the discussions that might need to take place and who to involve. And it doesn't necessarily give, I mean, they have some very institution specific stuff. So, you know, involving risk management and talking to the office staff about the patient's adverse outcome. And if it was a maternal death, kind of giving staff guidance about whether, you know, what to do if they're thinking about attending a funeral. And so I wouldn't say it necessarily meets everybody's, oh, wow, it doesn't work if you've got a background on. Let me turn my background off. I just wanted to hold it up so people could see it. So I can get this to Shannon and she can post it on the webpage so everybody can have
That
access
would be
to it.
great. Thank you so much. Very helpful.
But I would say we have not really, I mean, we have our basic things that we do, like we debrief. One of the questions everybody asks after a major event is, everybody doing okay? Does anybody need any additional support? Try to make sure there's some follow-up in the days afterwards. And if there's been a really significant event like a maternal death or unexpected death of a term baby or something else like that, we'll have our faculty and employee assistance program, which is a confidential institutional group that provides counseling and other support for people in lots of different settings, but including after medical events, to be present on the unit and be available for people to come kind of sit down and talk to them privately if they need some help or support or guidance.
We utilize that as well, and it's been very successful. We also have a confidential trust line that people can call and talk to and ask for support if they don't want to participate in the broader group discussions.
I would just like for some of us to have for us in our unit to have something that's more structured and very, no one has to think about what to do. It's just there for you. It's a resource and you activate it. Any other things that people wanted to bring up? I didn't see any other questions in the chat, but certainly people can ask questions verbally. I also know it's 1 o'clock and people may need to be dropping off to get back to other obligations, but we really thank everyone for participating in the webinar today.
Thank you, everybody. And feel free to email me if you have any questions. That works too.
Take care, everybody. Please stay healthy and look out for each other. Thank you, Jackie. I appreciate that. Thank you very much. Shannon, are we going to